we're going to go ahead and get started. Good evening and welcome to tonight's MBL Falmouth Forum. My name is Gina Hebert. I'm the MBL's Director of Communications here at the Marine Biological Laboratory. Thank you to all of you who are joining us tonight in person. We're so happy to see your faces after too long of a time of not being able to have you here in the Cornelia Clapp Auditorium. And we're also so happy for those many of you who are joining us virtually tonight. I'd like to note that tonight's presentation is the Herman T. Epstein Endowed Memorial Lecture. During his career, Dr. Epstein published dozens of papers and 2 books on the subjects of mind, brain, and education, and he was dedicated to the problem of how to improve education and the performance of children in school. I can remember during my time at the MBL, he used to teach one of our elder hostel courses too, for adult learning, and was always such an important part of communicating science to the general public. Dr. Epstein is also fondly remembered for his work on the creation of the Falmouth Forum series, and this endowed memorial lectureship sponsors a Falmouth Forum presentation in his name each year. Before I hand it off to our introducer, I'd like to remind those of you who are in the auditorium tonight to please silence your cell phones. And now I'd like to turn it over to Mike Fishbein, a member of our Falmouth Forum Committee, who will introduce tonight's speaker. Thank you.
Okay, well, thank you very much, Gina. So really, it's a great pleasure to welcome you here to the Clapp Auditorium. We're finally having an in-person presentation, which is always very exciting. And also, I'd like to welcome those who are watching this by way of the live stream. I'd like to thank my colleagues on the Falmouth Forum Committee for their help in bringing this lecture to you, as well as the assistance of the MBL development staff. So really, it's a great honor tonight to be able to introduce tonight's Falmouth Forum presenter, Dr. Leigh Hochberg. Dr. Hochberg's research is truly revolutionary, as you'll see tonight. The technology he's developing today has the real potential to restore motor function to those paralyzed with spinal cord injuries, stroke, and ALS. Restoring mobility to paralyzed people. I just want you to take a second to consider how life-changing that will be for millions of people around the world. I first learned of this research that Dr. Hochberg is doing a few years ago when a lifelong friend of my son's, Tyler Singer Clark, told me he was working at BrainGate to develop a computer-brain interface. I vaguely understood what he was saying, but the idea of a thought controlling a movement was so beyond my comprehension that I really didn't quite grasp what he was saying. And it wasn't until I saw a show on 60 Minutes that really drove home the point of what he was telling me. In that 60-minute segment, a woman who had a spinal cord injury was asked to think about moving a straw to her mouth. That thought generated an electrical impulse from her motor cortex, which was then transferred to a computer where the signal was modified and amplified. That enhanced signal was then relayed to an exoskeleton which executed her thought. The straw was brought to her mouth. The implications of that are truly staggering. And I'm going to leave it to Dr. Hochberg to tell the rest of this amazing story. So Dr. Leigh Hochberg is a vascular neurologist and neurointensivist at Massachusetts General Hospital. He holds a position as a professor of engineering at Brown University. He's also the director of the Veterans Administration Rehabilitation Research and Development Center for Neurorestoration and Neurotechnology at the Providence VA. Dr. Hochberg directs the MGH Center for Neurotechnology and Neurorecovery and is the principal investigator of the BrainGate clinical trials conducted through a close collaboration of scientists and clinicians at Brown MGH and the Providence VA Medical Center in Stanford. It's through this collaboration at BrainGate that much of this lecture data is derived. Dr. Hochberg's BrainGate team has published their findings in numerous prestigious journals, including Nature and The Lancet, and his team has also received numerous awards, including an international award for brain technology delivered in Israel by former Prime Minister Shimon Peres. The list of accolades goes on, but since time is limited, probably best to pause here and yield the microphone to Dr. Hochberg. So please join me in giving Dr. Hochberg a warm welcome.
Thank you, Mike. Very kind. Thank you. This is what we're going to watch me do for the next 45 minutes. We're going to look for the share window. Mike, if you're in the back, not this mic for a moment, but Mike in the back, the sharing green square has disappeared from us. Somebody's going to tell you about a technology where you put a chip in the brain. They better be able to use Zoom.
Oh, it says you're sharing, so.
Something's changed, yeah. Changed from moments ago? Yeah, but I'm just not seeing the green. So if you tell me things look good, then we'll...
You see it, Eric?
Thumbs up. All right, so we won't look for the magic green square anymore. That's fine with me. All right. The only thing left is for the folks who are here in the auditorium to be able to see. And all right, we'll take that as a yes. So with that, thank you, Mike, and thank you, Gina. And it is such a privilege to be here today to be giving this lecture, a series that was started by Dr. Epstein here at the MBL Falmouth Forum. I've had the privilege of being here in Woods Hole multiple occasions over the years. Often, for those who know, there's an annual neurosurgery course that's given here where neurosurgery residents have the opportunity to learn about neuroscience over the course of the week. And as I was driving here today, it really kind of reinforced to me that as I was driving down from Boston, from a big highway to a smaller highway to a smaller highway, that as one finds their way towards Falmouth, towards Woods Hole, the streets get a little bit narrower, the trees are a little bit more obvious, the pace slows, and one begins to think. And that is always what I've felt when I've come here, that it's a chance to think, it's a chance to learn, whether here at MBL, the other incredible institutions that are here in Woods Hole. And I just feel very lucky to be able to join all of you here in the auditorium today and as well on Zoom to tell you a little bit about the ongoing research that we've been doing for the past several years towards restoring communication and mobility. A few disclosures to mention. I have no personal financial disclosure, much to my dismay. But there are a few other things to mention. I'm quite grateful to the U.S. Department of Veterans Affairs and to the several institutes of the National Institutes of Health, as well as philanthropies who have really been together able to sustain this research for now more than 17 years. There's some other disclosures as well in part. This is somebody be telling you about an investigational medical device. And very clearly, I don't represent, in my words, any of the institutions that are listed there at the bottom. This is just you and me. So probably the most important slide by far are the great group of people that I get to work with every day across a number of disciplines, across a number of institutions. And I'm sure that many of you have seen slides like this before, but just to make really clear, it's not the people whose faces you see that you should pay any attention to. It's actually all the people on the right in the smaller font that have done all of the work, who really deserve the credit for what I'm going to be describing to you today. And only because I know his parents are in the audience and he's currently in my lab, and I wouldn't miss the chance to mention it. Oh, I can even reach him from where I'm standing. Tyler Singer Clark's parents are here tonight. So thank you. Thank you for being here. Thank you for Tyler, who's a wonderful member of my lab. All right, so in a few minutes, I'm going to begin to tell you about a technology that I hope is on its way towards restoring communication and mobility. But I spend, as Mike mentioned, some of my time in a neurointensive care unit where I see people who yesterday were able to walk and to speak without any difficulty, but suddenly today can't. Or they're progressively losing the ability to walk and to speak. And for that group of people and for many others, there's some fairly simple goals that I have, some things that I'd like to be able to say in the future. And those goals also are reflected in our own BrainGate research. These are really goals for the field that I'll be telling you about in brain-computer interfaces. So for somebody who's just had a spinal cord injury or a stroke, I'd like to be able to say, I'm sorry that this happened, but you'll be able to move again tomorrow. For somebody who's had a different type of stroke, a brainstem stroke, or has what's sometimes referred to as locked-in syndrome or LIS, I want to be able to tell them that they'll be able to communicate again easily tomorrow. And for somebody with ALS, that is amyotrophic lateral sclerosis or Lou Gehrig's disease, I want to be able to assure them that they will never lose the ability to communicate. So we're not quite there yet on any of those 3 points, but hopefully I'll be able to convince you that this field is on its way to getting there. So let me spend just a moment introducing you to, well, first to an MRI, but to a woman who in 1996 was tending to her vegetable garden, actually not too far from here. She got a little bit dizzy. She was 42 at the time, and she came inside and she sat on her couch next to her then 10-year-old son. And she got a little bit more dizzy. And then suddenly she couldn't move the left side of her body, and then she couldn't move the right side of her body, and then she couldn't speak. She had this MRI, so these are pictures of the brain, kind of from the bottom of the brain up to the top. And without needing to turn anybody into a neuroradiologist this evening, I can tell you that gray is good and white is bad. And most of her brain was gray, but there was one part that was bright white. That's the pons, middle of the brain stem, part of the brain that basically allows for the connections for the whole rest of the brain to find its way down to the spinal cord, and all true from the spinal cord back up to the brain as well. At that moment, she'd had a stroke, a tear in an artery in the back of her neck that had caused this brainstem stroke. And she was awake, she was alert, she could hear everything and she could feel everything, but she couldn't move and she couldn't speak. So for people like her, or for people whose neurologic injuries or illnesses may not be quite so dramatic, we're hoping to develop technologies that will restore communication and will restore mobility. And I'll come back and tell you a little bit more about her as the story gets a bit happier in just a little bit. So I'm going to be telling you about brain-computer interfaces. This is a phrase that a decade ago, it's possible that nobody here had heard of. It is possible that at least some people have heard of this phrase, brain-computer interfaces, brain-machine interfaces, over the past few years. But for any of these types of devices, there are 3 major components: a neural sensor, a decoder, and an assistive technology, or a technology. And I'm going to be telling you about one particular type of brain-computer interface tonight, but if you hear about any others, they still have each of these components. I'm a neurologist, so to me, that picture up there is a person. And for that person who may have lost the ability to move or to speak, if we want to try to restore that ability, there are a few things we need to be able to do. We want to be able to extract the intention to move or the intention to speak. And in order to do that, if we're designing a brain-computer interface sitting on our desk in the lab, we have to answer a few questions up front. What signal from the brain might we want to record from? There are lots of signals: electrical, chemical, others? What area of the brain or areas of the brain do we want to record from? And then knowing what we want to record and where we want to record, we have to choose a particular sensor in order to get that information out of the brain. Once we've got that in our hands, we need to take that information and put it into a black box. And that black box is the home of my friends in computational neuroscience, who in many ways have one of the greatest jobs in the world, is to figure out the language of the nervous system, figure out how to get a signal, maybe action potentials from neurons that are firing away, and how to convert it into real time back into the information that was originally encoded in there, that is, for example, the control of one's arm or hand. And just to check, knowing where I am, are there any computational neuroscientists here tonight? No, that's good. All right, because occasionally I have to apologize for collapsing their entire career to the letter A. It is a little bit more complicated than that, but it looks like I can get away with it for the moment. Before we leave our bench or before we leave our desk, we need to think a little bit about what we hope to do with this technology. So for somebody who's unable to move or unable to speak, if we could restore the ability to type on a computer screen or to use a tablet computer, maybe even restore the ability to use a text-to-speech application, or to control for somebody who's lost the ability to use their limbs, either their own limb, again, that is restore the connection between brain and limb, or to use some other exoskeleton. Any of those might be helpful technologies to restoring their quality of life. And just as a quick mention, for those who are familiar with the concept of stimulating the brain or deep brain stimulation for disorders such as Parkinson's disease, or more recently for some neuropsychiatric disorders, it is possible that this field of brain-computer interfaces is going to close the loop so that one day, and already beginning, we can record from one part of the brain, understand what that part of the brain is going to do, return an understood component of that brain activity back to the nervous system, and perhaps better tune how that brain is working so that that person is feeling better, that their health is restored, that their function is restored. So with great recognition that fundamental basic science is the only reason that we can do anything that we're doing today, and the importance of that fundamental neuroscience here in Woods Hole, I want to give credit to the last 50 years of neuroscience, where by and large, we've learned a lot about how voluntary movement in people occurs by studying animals who are voluntarily moving. So a paradigm for a long time for this has been to ask a happy, healthy monkey to play a video game. Play a video game and share. So here's an illustration of one. He's got his hand on a joystick. He's moving the joystick around. Every time the cursor's in the middle of the moving box, he's achieved his goal and he gets a squirt of juice. And for decades, people have trained happy, healthy monkeys to play video games and recorded electrical activity from different parts of the brain, trying to figure out how a single neuron relates to the control of voluntary movement. And as a field, we've learned quite a bit about voluntary movement through that type of paradigm. Now, as long as nobody tells anybody, I'm now going to skip the next 50 years and get us to 2001, where in John Donahue's lab at Brown, there were some happy, healthy monkeys that were trained to play video games. Misha Soraya in the upper left-hand corner, then an MD PhD student in the lab, not only trained the animals to play video games and were recording electrical activity, but there were two important aspects. One is that he was recording activity not just from a single neuron, but from multiple neurons simultaneously using a technology I'll tell you more about in just a moment. And also, he began to build a map between that brain activity and the animal's hand movement. So the animal was thinking about moving his hand to play the video game. You could listen to the electrical activity, and he was able to build that black box, if you will, that correlated the intended or the actual hand movement with the neural activity. Then he played a small trick on the animal, which was to disconnect the joystick. One can imagine, animal gave him a dirty look. What happened to my joystick? But the cursor that the animal was controlling kept moving. And it was moving in the way that the animal intended it to, as though it was using its own hand. Because the neural activity mapped through that black box was able to tell the computer where that cursor should go. And in real time, so these are real neural data, or at least real data from what was on the screen. The animal's job was to take the little green dot that it was controlling and to run it into the red dot. And every time it did so, it got a squirt of juice. And what you can see is a kind of wavy moving around green circle, but clearly the goal of that green circle is to get to the red dot. This animal was controlling the two-dimensional trajectory, the two-dimensional direction and velocity of the cursor on the screen just by thinking about it. This was the first time that there was two-dimensional control of a neural cursor, to introduce a phrase. And it was published in Nature there in 2002, was the demonstration, not that happy, healthy monkeys could play video games with their mind, but really it was the culmination of about 40 years of research, the goal of which was not only to understand the voluntary control of movement, but to hopefully be able to understand enough about neuroscience, understand enough about the brain, and be able to decode this neural activity fast enough that one might be able to restore mobility for somebody with paralysis. And as a result of that demonstration, there was then the development of what became known as the BrainGate clinical trials. So let me tell you just about a few things. First is the picture that's there in the lower left has a few names, the BrainGate array, the Utah array, the Neuroport array. I'm going to pass one of these around. Here's a really bad use of zoom, if you can all see that. The 4 by 4 millimeter little array has 100 electrodes on it. And Gina, I'm going to hand this off to you. Thank you. So as that's traveling around the room, take a look at the little tiny piece. You may have to shine your light phone or your phone light on it to see the little electrodes. That can be tapped into the top of the brain, originally in the university laboratory, now in our clinical trials, and can record dozens, if not 100 or more individual neurons from the brain of somebody with paralysis enrolled in a clinical trial. And if everything works the way that we want it to in this trial, there's a device that's in the brain, maybe more than one of these arrays, connected by some fine wires to a pedestal, which is the piece of titanium, the little plug that you'll see secured to the skull. That, in some videos that I'll show you, is connected to a cable that's kind of clunky looking, but I'll make that go away towards the end of the talk. And if everything works as we hope, that cursor will move around the screen, controlled by somebody who's unable to control their own hands, just thinking about the movement of their own hand. So in our BrainGate clinical trials, there have been 14 participants going back to 2004, and in part as a result of this research starting in 2004, there are several other institutions listed there that have been doing very similar research and also expanding this field so that we can get closer and closer to achieving these goals of restoring communication and mobility. So this is the ongoing clinical trial. The participants who we recruit are adults who have either cervical spinal cord injury, brainstem stroke, muscular dystrophy, or a type of motor neuron disease, including ALS. They're at least a year out from injury or diagnosis, and they need to live within about 3 hours of one of our clinical trial sites. And while needing to be able to communicate, our participants do not need to be able to speak. So if somebody is able to use their eyes as a method of communication, for example, looking at a camera that is able to track their eye movements where they can type on a screen, then we can enroll somebody who may not be able to move, may not be able to speak, but can still communicate using that type of technology. And the reason for the 3-hour drive time is while the surgery for placing this device, of course, happens in the OR, the rest of the research happens in their home. So right from the very beginning, we wanted to be able to not develop this in the ivory tower, not develop for those who've done any electrical engineering type research or neurophysiology research. We can't do this research in a Faraday cage, or we could, it would be very easy. We wanted to develop this where it actually needs to work, which is in somebody's living room, in their bedroom, or in wherever their place of residence may be in an assisted care facility. So everything that I'm going to show you today is from wherever that participant lives, and ongoing trial in these locations, and expect that these will expand in the coming months. So just for a bit of history, I'm going to go back to the participant that was recruited in 2004. He's here. You can see the cursor. You can see the top of his head. When he was 21, he was breaking up a fight at a July 4th beach party and was stabbed in the back of the neck. He had what's known as a C4 Asia A spinal cord injury, lost the ability to move his arms or his legs. And about 2 years later, 2.5 years later, he joined us to become the first participant in the BrainGate clinical trial, the first person in the world to have that array that's traveling around placed in the brain chronically. So what you'll see is, and hear, is you'll hear him talking. His voice is a little bit soft. He's mechanically ventilated. You'll also hear one of our technicians providing some instructions or working with him to find out what he's going to do. And then you see this medium-sized cable that I promise I'll make go away in a little while.
Okay, so here's the Cyberkinetics desktop. What are you going to do first?
I'm gonna open my email first.
Okay,
He's thinking about using his own
First
hand.
one.
you're going to open the
He's
first
unable
one.
to move. And as he's moving his hand,
And it says,
looking at Mike in the back, everything, we're good?
congratulations,
All right.
you were doing it.
So as he's attempting to
good.
move his hand, he's controlling that cursor on the computer screen.
Email.
Okay,
And these are simulated emails. I'll show you real emails in a little while. So
great.
although he's
Now
unable
can
to
you
move his
exit back
hand,
to the Cyberkinetics
I'm
desktop?
going to exit.
he moves that cursor, he opens the email.
Excellent.
For those who
what's
remember
next?
Mac Paint,
Next, I'd like to,
one of the things that
draw a
he
circle.
lost the
You're going
ability
to draw
to
a
do
circle.
as a result
Wow.
of the spinal cord injury was lost the ability to draw. So that's an inkwell at the bottom and a eraser at the top. Just like to draw a circle.
Let me try
And,
that again. I
okay.
erased
Give it another shot.
All right, let's try it again.
Here we go.
So also not a circle. But
You avoided the eraser that
as
time.
noted, he saw the obstacle and he avoided it.
Circle I can
And
do
so we asked him to do some other things for
Okay.
about 8 minutes and then asked him to try to draw the circle again.
Going to draw a circle.
All right. Excellent. Now let's try going back to the desktop. Very good.
And for anybody who's able-bodied who's ever tried to draw a circle with a mouse, it's actually not that easy a thing to do. So that wasn't too bad of a circle. And only because I'm somewhat self-conscious, I just want to point out that this is water. Thank you, Gina, for this. It's not the can that I'm usually thinking about when I think about water. So, so that was the first demonstration of somebody tetraplegic, that is unable to use his arms or legs or to move his arms or legs, controlling a cursor just by thinking about it, by attempting to use his own hand. That was back in 2004. You'll notice that the cursor's a little bit wavy. It's certainly not as fast or as smooth as somebody who's able-bodied, and we'll make some progress over the next handful of slides and videos. But even at the beginning, we wanted to see whether physical devices could be controlled as well as virtual devices. So on the left is a real prosthetic hand that might be used by somebody with a distal arm amputation. And our participant, we're going to hear him say open and close, so we know what he's trying to do with the hand. And depending on the audio, you may hear his response to being able to do this. It was very quiet. So I'll repeat what he said, almost. He is saying open and close, and he said close, and he saw it happen, and then he said 2 words. The first one was holy. And that was exactly kind of the response that we enjoyed hearing. But that opening and closing of a hand, even though that was done under his own control, that's from an engineering standpoint, that's kind of simple. It's a state decision. Should it be open or closed? And we know that we need to get better than that. So I'm going to begin to reintroduce you to the woman whose MRI you saw before, the woman who is in what's known as a locked-in state, awake and alert, but unable to move and unable to speak. And what you're looking at is a close-up of some of the waveforms of a few neurons that were recording. She joined us in the BrainGate trial about 9 years after that stroke, had one of these arrays placed in a part of the brain known as the motor cortex, very important for the control of the arm and hand. And a somewhat unknown question at that point is if somebody had lost the ability to control their hand, and we recorded from the part of the brain that used to control the hand, would that part of the brain still be trying to control the hand? Maybe during the Q&A we can come back to that. I know what the textbooks taught me when I was asked a similar question as either a medical student or graduate student. There's a lot of discussion about remapping of the motor cortex after a distal injury. So it was possible that the hand area of motor cortex was no longer going to be the hand area. So I will play this, and you'll hear what, at least to me, is Mozart.
Close your hand.
So right now, she's trying to close her
Relax.
hand.
Open your hand.
And you may be able to hear, and you may be able to see, there's a neuron that's just firing away
Relax.
as soon as she opens her hand or tries to open her hand. And when she relaxes, it becomes
Close your hand.
silent. When she closes her hand, it becomes really quiet. We're actually able to record 2 neurons from a single electrode. And remember, there's 96
Relax.
active electrodes on that 100 electrode array. And what this told us,
Open your hand.
I'll just listen to that music again. That is not the poorly tuned AM radio on your car. That is the sound of the amplified waveform of a neuron in the brain firing away, one of the 88 or 100 billion neurons in the human brain, as she's trying to do something. And we don't need any fancy math to know what that neuron's trying to do. It's trying to open her hand. So if we can understand that neural activity, if we can extract it and decode it in real time, we should be able to allow her not just to open and close her hand or open and close an external device, but to do some other things as well. So about 14 years after the stroke and 5 years after joining us in the BrainGate trial, she did some incredible work during this trial. We asked her what she wanted to do with the technology, and she said she wanted to take a drink. And we said, okay. So she's there on the right. She clearly survived the stroke, but didn't regain any functional use of her hand. She remained unable to speak, but she was just thinking about reaching out and grabbing that thermos. And because she's not able to move about her trunk because of the stroke, she needs to make sure that that thermos is lined up right in front of her, which is what she's doing now. And as she's thinking about reaching and grasping that, she's controlling that robot arm. That robot arm is doing what she's trying to have it do, reach her hand, and then bringing the straw to her mouth. So the next 30 seconds or so don't have anything to do with neurotechnology development, but still with her profound disability. She has a limited sip power. Takes a while for, I'll tell you for scientific precision, is a cinnamon latte into her mouth. And so she'll move the straw around a little bit as she's sipping it. I'll also mention that the engineer sitting behind her is under strict instruction to show no emotion. And I think she'll move that around just a little bit more. And I'll point out that up until this moment, for the 14 years before that, anytime she wanted to take a drink of something, somebody would need to pour the drink into the glass or into the vessel and put that on the holder that was attached to the headrest of her wheelchair and pour the straw or put the straw into her mouth. And here she's thinking about returning her arm to the desk so she can put the thermos back down. And so while that clearly wasn't the first time in 14 years that she'd had something to drink, it was the first time in more than 14 years that she was able to do so solely of her own volition. And so I will always remember that smile. She was happy, we were happy, and just because of that restored ability to take a drink by herself, to reach out, grab a cinnamon latte, and to take a sip. Still, that robot arm's a little slow. It's not as fast or smooth as somebody who's able-bodied, but it began to suggest that multidimensional reach and grasp movements could be extracted from just a handful, a few dozen neurons being recorded from the motor cortex. So Gina was from communications here at MBL, so I will point out that this was international news back in 2012 when it was published. I don't need to see pictures of myself, but I do want to point out that regardless of one's political leanings, this was a good story covered equally by both sides. And let's all hope that we can either continue or return that science is without any particular political persuasion. It's just what happened. So let's dive into the science just a little bit more. Vamsi Shavakula, one of our postdocs, now a neurosurgeon, asked one of our participants with cervical spinal cord injury to play a video game. And this is somebody who's unable to move his arms or his arm or hand, who's thinking about moving this robot arm in order to play the video game to capture the target, that is to put the aperture of the robot arm right over the target that's placed on the screen. So the participant's able to do this quite readily, and after doing that for a few minutes, we ask the participant to play the exact same game, but with a cursor on the screen. And the noise that you're hearing is just the computer audio saying northeast, southwest. So the participant could hear where to go, could see where to go. Those are very similar tasks. In fact, the only difference between those two is that one is a cursor and the other is a robot arm. So why am I showing you that difference? So one way to think about neural activity over a period of time, over a few seconds, is to collapse it all into a single icon, into a circle or a square or a star. And lower left, Carlos Vargas Irwin and David Brandman, both in the lab, they were looking at all of this neural activity as the participant was playing the video game, either with a robot arm or with a cursor, and they created a single graph. So this is one, not two. And what was discovered is that at each moment in time, not only could the neural activity tell us what direction the participant wanted to move, either the cursor or the robot arm, which is represented by the color, which is kind of clustered together, but the neural activity in the motor cortex also knew whether it was the cursor or the robot arm that was being moved, which is why the robot stars are over there and the cursor circles are over here. They could be completely, reliably separated. Not the direction, not the speed, not the force of movement, but what was being controlled could be detected from the neural activity. The difference between a robot arm and a cursor, maybe the difference between a spoon and a fork, maybe the difference between a tablet computer and a robot arm. It's a reminder that the power of this neural activity, the information that is encoded in there, even from a part of the brain that our textbooks tell us its job is just to move the limb, there's a lot more information that's in there that is more abstract and in many ways more exciting, and it speaks to just how much information we're going to be able to pull out of the brain in the future towards restoring communication and mobility in a very intuitive and I think natural, fast, reliable, and accurate way. So here's a video of one of our participants with ALS. You're looking from the perspective of the participant who's playing this video game. And here the participant who's unable to move his hand is controlling the tiny little white cursor and putting it on top of the target and then clicking by imagining squeezing his hand or attempting to squeeze his hand. There are two reasons to show this video. One is you may appreciate that the cursor is moving a little faster, a little smoother, and a little more accurately than it was 5 minutes ago, which was at that point 10 years earlier. But the other is just as a reminder of the laboratory that we're in, which is his living room. He was an artist. It's his artwork. It's his couch. So we're really testing this where it counts, where it needs to work. And when we saw that kind of point and click control, we knew that we were probably getting closer to being able to restore some type of communication. So this is an optimized keyboard. You'll notice the letters THE across the middle, because these are the most commonly used individual letters in the at least American English alphabet. And when I press play, we'll see that this cursor is moving around the screen. There's a woman with ALS who is copying the phrase that's at the top of the screen that she wanted to type. And as she gets on top, that is, as she imagines or attempts to move her hand, and she gets on top of the letter of interest, and she imagines clicking as though her hand were on a computer mouse, she acquires that letter, she types on the screen, and this, which was published back in 2017, our participants were able to get up to 39 correct characters per minute without using any of the word prediction that is common on one cell phone or tablet or other computer. And that, at the time, was about 10 times faster than any of the other brain-computer interfaces that at the time were recording from the top of the head, that is from the scalp, suggesting that this may be one of the benefits of actually doing surgery, to record from inside the brain, record from where the signals are being generated. So there's some other videos that are on screen in the upper right-hand corner, but when we saw these, when we saw this video of a keyboard that we programmed up being used fairly quickly and not too much slower than if somebody who's able-bodied on a cold night was walking down the sidewalk with 2 hands or 2 thumbs on their cell phone and was trying to type, they're probably not a whole lot faster or more accurate than that. But it dawned on us, why were we creating communication interfaces? Why were we using MATLAB or anything else to create those kinds of pictures? And there's actually an industry that's pretty good at making communication interfaces. So we did what many people might do, which is to hop onto Amazon Prime and to order 2 Google Nexus tablets. And they arrived 48 hours later. And then we turned them on. And we said, why don't we just connect our BrainGate system to the industry standard full power communication tablet technologies of a tablet computer. So in the upper left, there's a woman with ALS who is sending a real email, who's not using an assistive technology, but is using a technology, using a communication technology, using a tablet computer, and she's pointing and clicking at the letters, much as somebody who's able-bodied might, with a single finger at least, be typing on that screen. And she's sending an email to a postdoc, at this time in the BrainGate lab out at Stanford, to Paul Nerjukian, now a assistant professor of engineering out at Stanford. And in the lower right, gentleman also with ALS, he had 2 arrays, these recording devices placed in the motor cortex, therefore has 2 of these percutaneous pedestals and 2 of these somewhat, medium-sized gray soapboxes attached. Again, I will make those go away shortly. And he was just searching YouTube for ALS to learn more about the disease that he has. And they had the opportunity to chat with each other, to use the BrainGate system with a full-power tablet computer to text back and forth. And this, to us, thinking about that initial list of goals or missions that I want to be able to tell somebody with ALS that they will never lose the ability to communicate. One of the ways that I mean that is by saying that you should be able to use, with this or related technologies, the exact same communication technologies you used before the onset of your illness, before the onset of weakness. And whether one uses that for education or entertainment or employment, if you were using a tablet computer, we want to be able to restore the full, fast ability to control that industry-grade technology. Restoring the ability to control one's own limb is also a long-time goal of this field. I'll introduce you to the gentleman who you're looking at here. I'll pause the video for just a moment. He was riding his bicycle in the rain, and a vehicle in front of him stopped. Tragically ran into that vehicle, couldn't stop at time, and had a cervical spinal cord injury, lost the ability to use his arms or legs. He had, this is one of our team that was out in Cleveland, so with Bob Kirsch and Blue Adjuboy up at the top, and Jennifer Sweet and Jonathan Miller down there at the bottom. That team and their group not only placed 2 of the BrainGate arrays in the motor cortex, but also placed electrodes, stimulating electrodes into the arm, with the goal being that when he thought about opening or closing his hand or flexing, extending his elbow, which is something he couldn't do at baseline, that he'd be able to activate his own arm again. That is, his intention to move would enable the movement of his own limb. So while the shoulder elevation is happening by a brain-controlled prosthesis, that is mobile arm support, that flexion and extension of his elbow, also his ability to grasp the fork, is enabled because that's what he's thinking about. That's what he's trying to do. She wanted a cinnamon latte. He wanted mashed potatoes. We oblige. And this was the first time that he was able to feed himself, since his injury, solely of his own volition, to move his own arm again, decoding. He's thinking about picking up the mashed potatoes, and we're decoding that brain activity, translating those electrical potentials into stimulation of the muscles of his arm, allowing him to bring the mashed potatoes to his mouth. Still slow, still rudimentary, but a demonstration that we should be able to get towards reconnecting brain to limb ever faster and ever more fluidly, and both the recording and the stimulation sides of these fields continues to improve. So one of the questions that's often asked is, this whole thing that you're talking about must take a long time for somebody to learn. How quickly or how long does it take for somebody to use a brain-computer interface? So when I press play momentarily, we're going to see one of these standard tasks played with a cursor moving around a computer screen. There are actually two versions. There's what's on the big screen, and then in the upper right. There are two different people doing this at two different times. I'll tell you about the upper right in a moment, but focused on the center, when I press play, our black box, that is the decoder of neural activity, the map between the brain and cursor movement, knows nothing. It's what we call naive or uncalibrated. It basically is starting at 0. Nevertheless, our participant knows what the goal is, which is to try to move the cursor over to the target. And so we press play, we ask him to start doing this, and the cursor, exactly as expected, does nothing useful. It's kind of floating around in no particular direction. But every 3 seconds, we're re-listening to that brain activity, and we're remapping it towards the intended direction of movement. And we know what the participant's trying to do because we put the cursor and the target on the computer screen. And as that map is getting built, getting better every 3 seconds, about 38 seconds goes by, and what's emerged from nothing is the beginnings of fair, maybe good, two-dimensional control of the computer cursor. So in tens of seconds, we went from nothing to two-dimensional control of the cursor. And this isn't because the participant, the user of the system, had to learn anything. They were just trying to move their hand the way that they had moved their hand prior to the onset of injury. What we had to learn, what the computer had to learn, what the software had to learn, was how to build this map. And that can happen in tens of seconds. Now, interestingly, in the upper right-hand corner, the exact same movie, different participant, but this participant was doing this the very first day and the very first time that they had ever tried to control the cursor on the computer screen. In fact, what really happened is that having seen what was on the middle screen there first, David Brandman in the upper left went together with the team over to visit the participant who had never used a brain-computer interface before and said, here's what we want you to do. We want you to try to capture the target. We're going to see if this cursor moves at all. First minute went by, cursor's floating around, not going anywhere useful. Another minute goes by, third minute goes by. Nothing good is happening on the screen. The cursor's floating around. And then the participant turned to David and said, when do you want me to start? You can imagine one's trying to get their PhD, seeing their entire thesis fall apart in front of their eyes, and then just to comment, oh, so reset button, how about starting now? And 40 seconds later, again, emerged the two-dimensional control of the computer cursor. So even though this is a relatively simple two-dimensional control, I think as we go forward, we're still going to be able to provide quickly restorative ability for communication, possibly for mobility. So to those original mission statements, restoring communication with a tablet computer and being able to do so tomorrow really means being able to do so quickly and not requiring a lot of learning, except on our side, on the computer side, which should be able to happen at least to begin with over a period of minutes. There's a few other places that I think this field is clearly going to be headed. One is not just controlling whatever one would be able to control by moving or attempting to move one's hand, but actually decoding attempted speech. So thus far, we've been recording from parts of the brain that are dedicated in some ways to controlling the arm and the hand. That is, part of the brain in the motor cortex that controls the arm and the hand. But a couple years ago, even recording from that place, we asked our participants to speak and recorded the brain activity while they were speaking. These are Guy Wilson and Sergei Stavisky who were doing this work. And these little dots in different colors, we asked our participant to speak these different phonemes that are listed. And you might be able to make out that as each of these phonemes was being spoken aloud, there were slightly different patterns of neural activity. And it turned out that across these 10 phonemes, we were able to decode with about 84% accuracy which of those phonemes were being spoken from just the brain activity, and probably most importantly, from the brain activity in the wrong part of the brain. We were recording from the part of the brain that's important for arm and hand movement, not from a speech or language related area, which tells us two things, I think. One is that when we're actually recording from the, quote, right part of the brain, we should be able to do a whole lot better. And the other is that this picture that we have in our mind that I had to fill in the right dot in med school or grad school on the multiple choice question, that this part of the brain does that, and the other part of the brain does something else. It is not nearly as simple. It is much better than that. Functions are much more distributed across different parts of the brain when we're looking not at big blocks of brain, but at one neuron at a time. When we have the resolution to be able to record from ensembles of individual neurons, even a few dozen or a few hundred of the tens of billions that we have, there's a ton of information that will be able to be extracted about communication, mobility, and perhaps about things more abstract. So I think really exciting towards the development of a real-time speech prosthesis. A little bit more about communication. We've talked about point and click control. We've talked about speech. There's another way that people who are able-bodied communicate, and that's by handwriting. And so that's Frank Willett in the upper left-hand corner asking somebody with cervical spinal cord injury just to think about writing or to attempt to handwrite individual letters. And the green squiggles that you see are what we might call a neural trajectory. They are the picture of the direction of cursor movement that is extractable in real time as somebody attempts to write each of the letters of the alphabet. Now, and that handwriting is better than my handwriting, so that's actually not too bad. But that idea of a neural trajectory makes sense, and it makes sense from a neuroscience standpoint, but we can do a whole lot better than that because we have computers and we have artificial intelligence or deep learning or machine learning. And it turns out that if instead of trying to recreate a trajectory, one just asks the question, what is the neural signature of the letter B and the letter H and the other 24 letters of the alphabet? Extract that information, put it through a neural network, and let the machine, if you will, let the math figure out what letter that person's trying to type. Here's an example. Again, somebody with cervical spinal cord injury who's been asked the question on the screen, and what you're now seeing in real time is the attempted handwriting being detected one letter at a time and converted into the letters that he's writing or typing or thinking about. And through this, somebody with spinal cord injury, cervical spinal cord injury, unable to use his hand, but attempting to handwrite, had the full vocabulary available to him of 26 letters plus a few points of punctuation. You can see the comma up there. Achieving up to 90 characters per minute without a language model, about 94% accuracy, and with a language model could get up to 99% accuracy. So at that level of speed and accuracy, we are that much closer to that goal of being able to say we can restore communication. And perhaps if this can get further converted to restoring mobility, but certainly towards that goal of restoring communication for somebody with ALS or other forms of neurologic injury, I think this is really, to us, a promising opportunity. And yes, so we all agree with that. And I'll just point out that we actually did miss a letter there. There's an R missing from the word prefer, just to demonstrate that we still have a little bit more work to do. You've been looking at a whole bunch of big gray boxes that are attached to the top of the head, not a future medical technology. But much like cardiac pacemakers that used to have wires coming out of the head and deep brain stimulator, or out of the chest, and deep brain stimulators that had wires coming out of the head, these are good ways to begin to learn how these technologies should be refined. It's easier to fix things outside of the body than inside of the body. But what was developed at Brown a handful of years ago was something that I occasionally carry in my pocket, is a wireless transmitter that can take that full bandwidth of neural activity that's attached to the top of the head, but no longer tethering our participant or our user to the rack of computers, and can beam that neural activity to some nearby antennas. And here's one of our participants kind of laying on his side down at the bottom. That's a fluorescent red or orange neck pillow that you see. And what's a little blurry here is one of these wireless transmitters beaming the neural activity related to his intended movement. And on the screen is I think a Surface tablet. And so I'll press play. And he's thinking about moving his hand across that tablet. You can see the cursor that's moving across the tablet. He gets to play, and he clicks on it. And so that's Pandora. It's his music that he wanted to play. And in many ways, and he's gonna move over now and
Give it the thumb.
like the music.
There you go.
Those are pretty tiny icons to point and click on. And while that video in some ways is, well, that's just Pandora and that's just a tablet. And to me, that's the point, is that we don't need to create exciting new communication technologies. We have incredible ones. We need to re-enable the ability to use them. And here is somebody who is wirelessly thinking about moving his own hand and controlling that tablet, much in the same way as he did before the onset of his injury. So towards wrapping up this field, of which I've been able to just represent a little bit, is neuroengineering ever better devices that can record neural activity from the brain, figuring out how to decode that activity in real time to restore communication, whether by tablet computers or in the future, we hope, by speech, for the control of either exoskeletons or prosthetic arms or soft robotics, and to reconnect brain to limb, to reanimate a paralyzed limb. In order to get there, there's still plenty of work to do. The signals themselves may not be consistent all the time. There are different effectors or different devices that people would like to be able to control just by thinking about it. So all of those things that are there in yellow are important, either areas of science or concepts for us to be constantly working towards and thinking about. And because I'm a dyed-in-the-wool academic, I of course put the word commercialization in a smaller font. But I can't overstate how important it is that this field needs to get to industry. And thankfully, over the last few years, several startup companies of different sizes have decided that this field is now mature enough for them to be investing their resources to develop actual products. Because neither university laboratories nor academic medical centers make the final form of a medical device. They certainly don't market it and support it. That's the job of industry. And now, whether working with industry or independently, I think that this space, if you will, of neurotechnology and brain-computer interfaces is matured enough that very happily there are industries that are investing their time, their focus, and their resources so that we can hopefully soon be able to say to somebody who's in the intensive care unit or somebody who's been diagnosed with one of these illnesses or injuries that results in a loss of movement or speech, there's a technology, it's available, and it can restore communication and mobility. And towards that goal, this is some of the great team that I get to work with every day. Clearly, this is a pre-2020 picture, and I look forward to us all being back together at our annual summit meetings or elsewhere to pursue this research. And with that in mind, I'm really looking forward to answering any questions that you have. I just want to thank you again for the real privilege of being here this evening and joining you all at MBL. And thanks so much.
Free to raise your hand. I'll come to you, or Mike will come to you.
Oh, thanks. Yeah, thanks so much. In the abstract, I think it mentions neuromodulation of neuropsychiatric illnesses. Could you elaborate a little bit more on that?
Sure. So so I said, and thank you for your question. So today there are disorders, neuropsychiatric disorders. Let's choose one: bipolar disorder, just to choose one. The movement between mania and depression, or obsessive compulsive disorder or depression, just to mention two others. There are attempts, and in the case of obsessive compulsive disorder, already a cleared approach of using deep brain stimulators placed in different parts of the brain for different disorders with the goal of modulating the neural activity to try to restore some degree of that person's mental health or their comfort with what it is that they want to do next. That is to change in some small way their own brain activity so that they are feeling better themselves and across any of these axes. The standard technologies are placing one electrode, sometimes two, or two devices that may have 2 or 3 electrodes, maybe 4 electrodes on them, and basically turning them on and leaving them on. It's an open loop system. Same technologies that are used, I should mention, for Parkinson's disease, for example, for movement disorders, placing a deep brain stimulator and turning it on and relieving some of the symptoms of Parkinson's disease. But particularly in neuropsychiatric disorders, and maybe for other movement disorders, that the way that those disorders express themselves, the symptoms can change over time, and not over a period of months, but over a period of minutes. And it's possible that rather than turning on the machine and leaving it on, it might be better to modulate that activity, to change that activity. So that, using the example of bipolar disorder, if somebody is in a condition where they're feeling more depressed or they are more depressed, there may be a certain pattern of neural activity that would be good to stimulate. But first we need to know from the brain activity that that person is in a certain condition, and then to adjust the stimulation. So what we're really talking about is recording and figuring out what the neurophysiologic signatures are of health, or of the proper, the condition that that person is hoping to be in at that moment. And I think we're going to be able to do that. I think that, just to state the obvious, any of these disorders are the result of disordered neural activity in the brain, which is why they're expressing themselves the way that they are. And it should be straightforward to then be able to detect the changes in neural activity that are responsible for that undesirable or less healthy brain activity. And if we can do that, then we should be able to do something about it in real time. And so I think that's where we're headed in terms of closed loop neuromodulation. And in fact, there's been several studies that are ongoing that are looking at doing just that, recording a little bit of brain activity and acting on it.
We have a question from our Zoom audience. Eric will read it.
Where in the brain of the subjects do you think the decisions to move are being made? Is it possible to answer this question through more of these kinds of experiments with clinical subjects?
So thanks for that question online. So the decision to move, we are probably, well, there's a few ways that I can answer this. I think that we are some distance, not necessarily measured in centimeters, but at least measured in neurons, away from the actual decision of whether or not to move. But let me provide a little bit more neuroanatomic accuracy to that answer. So we're placing electrodes or arrays right now in the precentral gyrus, which is what generally, informally, people would refer to as the motor cortex. Now, if we dig into the neuroscience a little bit more, where we place these arrays really at the top of the brain is probably not in a person the primary motor cortex, but it's one step either backwards or forwards, depending on your perspective. It's in what we would call the premotor cortex, most likely. That is in a part of the brain that is responsible for planning the upcoming movement, more so than in the part of the brain that's actually directly responsible, or at least the neurons that are directly responsible for executing that movement. So from that perspective, we may kind of, sort of, a little bit already be in a part of the brain that is involved in the decision to move. Having said that, there are lots of other places in the brain that one could potentially be recording from to get that much more insight, not only into what somebody's attempting to do at that moment, but maybe what they're attempting to do in a sequence of movements. And the more that we can understand what's coming next, the better we'll be able to allow that person to actually perform that movement. And if one thinks, I don't know if there are any musicians who are here today, I suspect that there are, whether playing the piano or playing the trumpet or playing any other instrument, one knows, if one knows the piece that they're about to play, what the next several notes will be, and the performance of that well-practiced piece is automatic. It is well known to that person, and that means that we should be able to perceive from somewhere in the brain what that upcoming second, third, fourth, fifth in advance next note will be, or next movement of the fingers along the strings of the violin or the keys of the piano. So one of the real exciting opportunities for this field will be to not only do what we're currently doing with a few small arrays in the brain, but to be able to record from more and more different areas to get more abstract information and that much more resolved information about what the current intended movement is, what the current desired speech may be, and then to allow that person to execute that movement or speech.
I just want to ask if it's an oversimplification to say that the exoskeleton is reading the mind of the patient.
So I would say that the devices, let me answer that question in a different way. Yes, it would be an oversimplification. I want to make sure that I don't inadvertently suggest that these technologies are anywhere near reading anybody's mind. On a really good day, we're able to know with confidence whether somebody's trying to move their hand to the right or to the left, which I think everybody will appreciate is a big, big distance and an important space between an attempted movement and reading one's mind. We're, thankfully, perhaps in many ways, nowhere near what might be implied by reading one's mind. We're, at best, trying to understand how to allow somebody to control something voluntarily in real time, much the same way as they would have controlled their own arm or hand prior to the onset of injury or disease. And just let me look and double check that I actually answered the question that you were asking. Okay, thanks.
We have one over here, Leigh.
Oh yeah, sure.
Yeah, thank you. I want to come back to the example where somebody tries to move his own arm, and moving one's limb is so much more than just giving the instruction to move, but you actually have to know where it is, where your arm is, and where you want to move to, and is it hurting? Is it hurting? Are you exerting something? Like, I felt that he must have kind of gotten, the arm must have hurt after a while when you keep it up always there. So is there much more than just moving, and can you connect to that?
Yeah, so so one way to think of this question is what I showed you, and even the simple kind of examples that we have, is somebody thinking about moving their own arm, and either their arm moving or a robot arm moving. But for somebody who's able-bodied, just as you were saying, the position of their arm is known to the brain. It's known as the kinesthetic sense or joint position sense. A position of the hand or arm is known, whether the eyes are open or closed. And depending upon what neurologic injury or illness one has, the brain's knowledge of where that joint is, or those joints are in space, where that arm or hand is, whether it's in their pocket or on the table, may or may not be known. In somebody with a complete cervical spinal cord injury, the information of where that joint, where that arm or hand is in space is unknown, if you will, to the brain, unless one is looking at it. While in somebody who's with ALS, who is also unable to move their arm or hand, that sensory information is intact. So if we think just about, as you were describing, somebody with spinal cord injury, it might be better, and there's some nice work from the University of Pittsburgh suggesting that it will be better to not only be able to execute the movement, to move the arm and the hand, but also to restore some sensation as that arm or hand is being moved. And if one uses basically the same device as was floating around, that array, one can stimulate the sensory cortex and begin to return just a little bit of real-time information to the brain about, for example, whether a finger has been touched. Maybe begin to get some sense of information of the force that's being applied or the position that one's elbow or shoulder is in. And I think there's every reason to believe that being able to restore that sensation, closing the loop in that direction, is going to make the motor control that much easier and more natural.
Thank you. Does this relate to proprioception? And if so, how does the black box tell the arm where it is?
Yeah, so this proprioceptive sense is another way of describing the kinesthetic sense or the joint position sense. I would use all those words basically about the same way. The black box that I put on the screen was a unidirectional black box, which is that it is, if we can decode, for example, the three-dimensional point in space at which somebody is trying to move their hand, we can then send instructions to their hand or to a robot arm or to another device to approach that location. And presumably as well what the orientation of the hand should be, whether the hand should be open or closed, which is really a multi-dimensional movement. But you're right that ideally, once the limb is there, we want either the brain to know that the limb is there or our own system to know that the limb is there. And keeping our system aware of what it's done moments ago is straightforward. The making sure that the person's nervous system is aware, other than by vision, which still counts and is useful, but actually has some of that proprioceptive sense, I think is a wonderful and relatively new aspect of this field of returning proprioceptive sense to somebody, so that they would be able to not only see but feel their own limb moving in the way that they wanted to. And another reason why this will be incredibly important is if one reaches into one's pocket to grab your keys or a coin, the ability to distinguish between those two is not really a motoric event, it's a sensory event. And if we're really going to get to that ability and that precision and that fluid, intuitive movement where sensory information is being restored and motor information is in real time responding to it, then restoring sensation is going to be, and it already is, a really exciting part of this field.
We have time for one more question. This gentleman right behind you.
Thank you. So 4 or 5 slides ago, you spoke about trying to decode the effort to speak, and admitted that you were in the wrong part of the brain. So it raises a number of questions. So I was trained as well that that part of the brain doesn't have much to do with speech. So what were you really picking up was the effort that one would make to move their mouth and tongue, or was this really a spread of impulses from the speech part of the brain?
So the first thing is that I'm happy to report that we had the same teacher. Or the same textbook, or we took the same exams. I think what this really is that the classical, purposefully cartoon-type illustration of the brain, the homunculus, which was described as a cartoon and illustration by Penfield and Bouldry when they wrote it, has been overinterpreted to mean that every neuron in that location in the brain is only responsible for doing that thing. That particularly when one stimulates the motor cortex, if it's the hand that moves, then every neuron underneath there must be related to hand movement. And I think the good news for the field, and the good reminder for me at least, is that all of these functions are probably much more distributed across the brain at the level of individual neurons. So I think what we were recording there was neurons that are actually involved in the control or in the plan to control the articulators. Now, we're in the wrong part of the brain, so there's probably a whole many more neurons, a little few centimeters laterally than where we were, that are responsible for that movement. But I don't think that it's an artifact. I think that there really are neurons across the motor cortex. And there's some nice work by Frank Willett and others that show that pretty much wherever we are in that motor cortex, we're likely going to find some neurons that are engaged in the control of other parts of either the limb or other parts of the body. And that distributed function probably has a lot to do with how one can recover at least some function after stroke. If there was only one part of the brain that was totally and exclusively responsible for controlling the hand, then if somebody were to have a stroke that affected that part of the brain, if what I said was true, which thankfully it's not, there wouldn't be any recovery of hand function. And sometimes there is some recovery. And I think part of that is because there are other neurons that have some of this role, and one, through rehabilitation, there can be some learning. And I should mention that part of what I hope this field will do will not only help us to re-understand approaches to rehabilitation, but these technologies will actually be able to contribute directly to reconnecting parts of the nervous system that might facilitate the rehabilitation after stroke. So I hope that kind of broad answer to the great opportunity we have from recording different parts of the brain is helpful. And
thank you so much again for coming out tonight. Thank you, Dr. Hochberg, for joining us.
Thank you. Thanks so much.